Good morning. I'm Dr. Tom Jeanne, Deputy State Health Officer and Deputy State Epidemiologist with Oregon Health Authority. Thank you for joining us today for our latest update on the state's ongoing management of COVID-19. This is the first of our monthly media availabilities to provide an update on COVID-19 in Oregon. It's now been a little more than a month since OHA announced its priorities for the next phase of the pandemic and outlined that framework in the RISE plan. Resilience and support of equity. Our approach prioritizes protecting people at highest risk, reinvigorating our communities, and advancing our work to eliminate health inequity. Today, I want to provide an update on the measures that are still in place and what we know from our more recent data. In Oregon, the emergency phases of the COVID-19 response have ended. However, the pandemic is not over, and several measures remain in place. These include vaccination requirements for those who work in healthcare settings, congregate care settings, and K-12 schools, and mask requirements in healthcare, long-term care, and other congregate care settings. Thanks to Oregonians' ongoing actions, including choosing to wear masks, getting vaccinated and boosted, and staying home when sick, our state has avoided the worst outcomes seen in many other states. Oregon continues to rank among the most successful states in the country in our response, thanks to so many of our residents protecting each other, our vaccine providers who continue to serve all Oregonians, our healthcare workers, and the collective actions of our many local public health, community, and tribal partners. We continue to see relatively low numbers of hospitalized patients with COVID-19 illness, averaging fewer than 100 patients a day during April. A significant drop from the more than 1,100 hospitalized patients we saw during the Delta and Omicron surges. However, our daily case counts have seen a steady rise since their lows of 200 and 300 per day at the start of the month. The most recent 7-day average is 600 cases per day as of April 19th. We know from experience that hospitalizations tend to lag behind infections, so we expect those numbers to eventually rise too. It has been a little more than 4 weeks since the lifting of mask use in most settings, and some of the jump we see in case counts is likely tied to less mask use and more Oregonians gathering indoors and returning to pre-pandemic social activities. The proportion of cases that are reported to public health also has likely declined, with more home tests available. We also know that we're confronting a particularly stubborn adversary, this time in the form of an Omicron subvariant known as BA.2, which is now the dominant variant in Oregon, as it is in much of the country. A number of these factors are addressed in the state model forecast that is now released every other week by our colleagues at Oregon Health and Science University. The most recent model projects a slight increase in hospitalizations over the next 2 months. The good news is that it's expected to be far below the surge levels we saw late last summer and this past winter. And there's more good news. Most Oregonians are now protected by safe and effective vaccines. More than 83% of all adults have been vaccinated, and more than 3 in 4 adults have completed their vaccination series. To those who have not yet received a vaccine, consider getting vaccinated at a vaccine provider near your home or at one of the larger vaccination clinics around the state. If you haven't discussed your vaccination status with your provider, consider that conversation on your next visit. For those who are eligible, consider getting a booster dose. Remember, all vaccines and booster doses are free to anyone, regardless of residency status, and are available in every county in Oregon. Lastly, we want to encourage residents to develop a plan for themselves and those they care for. All of us will need to make decisions about the amount of risk we're willing to take. For most of us, this means understanding one's own level of risk based on our age, medical conditions, and vaccination status. For others, that also means thinking about those who they live with and work with. In addition to having masks readily available, residents can also keep COVID-19 tests and a thermometer in your home. For those at high risk of severe illness from COVID-19, consider talking to your healthcare provider now. You may be eligible for early treatment in the event you get infected with COVID-19, and you can learn what the process would be like. If you do not have a healthcare provider, you can reach out to a local community health center or call 211. OHA will continue to play an active role informing Oregonians of all backgrounds, languages, and cultures about the importance of vaccination and steps to take for individuals at risk for complications from COVID-19. OHA will also continue its efforts encouraging residents to keep well-fitted masks at the ready when they go to work and out into the community. Wearing a mask is one of the simplest and least burdensome steps that we can take to protect ourselves and others. This pandemic has been difficult, but where we are now is a brighter spot. Unfortunately, we're not done with COVID-19 yet, but we are closer to normality than ever. We thank Oregonians for continuing to step up to protect themselves and their communities. And with that, we can now take some questions. And I'll be joined by our medical director for communicable diseases and immunizations, Dr. Paul Cieslak.
And just a reminder to our media friends that if you have a question, please raise your hand and then you will be added to the queue and I'll call on you. So thank you. Okay, our first question comes from Rob Manning with OPB. Go ahead, Rob.
Hi, I wonder if the models that you have, whether the models or whether there is insight into what effect, because you made the connection between lifting of masks and the rising case counts. What do you think will happen to case numbers and hospitalizations now that masks are no longer required on public transit, airplanes, and airports?
Thanks for the question, Rob. Yeah, as we've heard, the lifting of the federal mask mandate for public transportation has just happened. Our model does incorporate, or I should say OHSU's model, and does incorporate some estimates of masking and how that affects cases. It's hard to say because this is in context of everything else that's changing, seasonal changes, changes in people's attitudes. So I don't think we have a specific estimate as to how that recent change at the federal level might impact cases. What we know is that cases are already going up in Oregon. They're going up around the country right now. We're going to continue to see that. We're also going to continue to see an impact on our hospitalizations eventually here and deaths, just as those cases go up. But the projections, I have to emphasize, so far look like any peak we're going to see in the near future here is going to be quite a bit lower than our large peaks from last year and this past winter.
Okay, thank you, Rob. Our next question comes from Tim Groover with the Albany Democrat-Herald. Go ahead, Tim.
Yes, is there any threshold you imagine actually meriting the restoration of any kind of mask protocols in Oregon should cases continue to trend up in the near future?
So thanks for the question, Tim. We don't have any thresholds right now that at which we would consider that. We are looking at our numbers. We are constantly evaluating, and right now there are no plans to do that. What I can focus on is where we are today is much different from where we were a year or two ago. We've got over 80% of our population with immunity. Some level of immunity to COVID-19. We've got effective therapeutics and treatments for COVID. So any impact on hospitalizations and Oregon in general is going to be definitely much less this time around. So we hope that kind of intervention would not be required.
Thanks for the question, Tim. Our next question comes from Zoe with the St. Helens Chronicle and Clatskanie Chief. Go ahead, Zoe. Zoe, we'll come back to you. Our next question is from Julia Silverman with Portland Monthly. Go ahead.
Hi, thanks so much for taking our questions today. I have two, if that's okay. First off, I'm wondering if the state is making any concerted efforts to reach out to elder care settings where they know that vaccination rates might be lower, given that that population is considered particularly high risk. And number two, I'm wondering if you mentioned therapeutics, could you give us an update on how easy that is to access in Oregon right now for people? Because it sort of feels like, maybe there hasn't been as much public awareness of that option at this stage. Thank you.
Yeah, thanks for the question. I'll take the first one, and then I'll turn it to Dr. Cieslak for your second question about therapeutics. We know that there are very clear populations in Oregon that have higher risk from COVID-19, and the elderly and people with chronic medical conditions, people who live in congregate care settings or long-term care settings across the state are certainly at much higher risk for severe illness from COVID-19. So we have worked hard with those populations and those settings to really increase understanding of the disease and what we have to prevent it. And a big part of that, of course, is vaccination. And so I don't have anything specific about elder care, but again, we've worked really hard with those populations to try to increase vaccination, not only among residents and patients, but also among staff. And then Dr. Cieslak, can you speak to therapeutics?
Sure. What I can tell you is that our supply of Paxlovid, which has an 89% protection, offers 89% protection against hospitalization in patients who take it soon after their COVID-19 symptoms begin, is available at Test to Treat centers around Oregon. And you can find one of these Test to Treat centers on the federal locator. The URL is https://aspr.hhs.gov/test-to-treat and find a location near you. This is the sort of thing where you need to get a diagnosis, and then the medications do require a prescription. And so these are facilities where the ability to dispense is tied to the ability to get a prescription. So it should be sort of a one-stop shopping for people who think they might have COVID-19 and are at risk for severe disease. Did I say we're getting over 1,200 courses of this per week now? So I think considerable amount of it out there.
Thank you, Dr. Cieslak. All right, we're going to go back to Zoe with the St. Helens Chronicle and Clatskanie Chief. Go ahead, Zoe.
Hi, so my question is about breakthrough infections. So I understand that the OHA has made statements about breakthrough infections increasing proportionately to the number of people getting vaccinated. They've doubled from about December to April, from about 23% to 47% of COVID infections are breakthrough infections. And at the same time, the uptick in vaccinations has slowed from December to April. So how does the Oregon Health Authority explain this phenomenon?
Yeah, thanks for the question. I'll start, and maybe Dr. Cieslak can add. So, we now have 83% of Oregonians who've received at least one dose of vaccine. However, not all of them have completed their course or gotten a booster. And so if they got a first dose, well over a year ago, they may have some waning immunity, more likely to get a breakthrough infection. And so at this point, we have the majority of Oregonians who would fall into that category of breakthrough if they were to get COVID. And that does not mean that the vaccines aren't effective. These vaccines are highly effective. We just have to remember that the goal of vaccination is really to prevent severe illness and death. They're not going to prevent every single infection or some of the milder or asymptomatic infections, but they're really effective at what we need them to do, which is keeping people out of the hospital. Dr. Cieslak, anything to add?
Sure, I'll say that we know that the vaccines do not aren't perfect at preventing infection, and that in fact, immunity against getting infected from the vaccines will tend to wane over time. And the booster dose really offers a lot of additional protection in people who have had the primary series. So our breakthrough infections are, any detection of COVID-19 in someone who has had the initial 2-dose series of mRNA vaccine or single-dose Janssen vaccine. And we're gonna see those indefinitely into the future. But also remember that if everybody's vaccinated and the immunity isn't perfect, then every infection will be a breakthrough infection. So the fact that 40-something% of the infections that we're seeing are occurring in the 80% of the people who have been vaccinated means that the vaccine is still offering significant protection. That means 50 to 60% of the infections are occurring in the 20% or so of people who haven't been vaccinated. So the vaccine is still protecting against infection. But what Dr. Jeanne said is really relevant. Even if you're not totally protected against getting any COVID-19, you still have significant protection against getting hospitalized for it or being in the intensive care unit from it.
Thank you. Our next question comes from Fedor Zarkin with the Oregonian. Go ahead, Fedor.
Hi, thank you. Dr. Jeanne, so you mentioned that there's the current case count could be an undercount because of the prevalence of at-home testing. Do you have any method for gauging the width of that gap? Like, what is exactly, to the extent possible, the undercount, and why is an undercount potentially a problem, if at all, and what can OHA do to make up for it?
Thanks, Fedor. Yeah, that's a really great question. Well, I would say first that we know it's an undercount. It's not even a likely thing. We know for sure that we're missing some cases because, yeah, many people are now using at-home tests, and those are generally not reported. Some of them do get called into public health, and we do include those where we can, but we know that many of them are not. I would say, from what we've seen in the literature and reports, it could be on the order of, 5 to 10 or even more times an undercount. So we're missing the majority of cases, in other words, just because of that reason. Whether that's a problem, I'm not sure it's a huge problem, because based on lab-based reporting from those tests that do get reported to us, we can still follow the general trends, even if the actual magnitude is not exactly right. And at this point, again, what we care about the most and what we're worried about the most is the hospital capacity, the ability of our healthcare system to treat people and keep people healthy and alive if they get COVID-19. And we have very good tracking of the number of COVID patients in hospitals and the number of COVID deaths. So those are the kind of the anchor that we're tying this to. And we can still follow trends based on case and test reporting, but we do know that it is absolutely a significant undercount.
Just to make sure I got that right. So you're saying that the actual number of people testing positive, say through at-home tests and lab tests, could be 5 to 10 times as much as what's being reported right now?
It could be. There was one report from the IHME up in Washington State that was estimating a 14 times undercount. I think that might have been nationally. So this is not Oregon specific, and it's just a ballpark estimate.
Okay, so say 10 times, that would be 7,400 cases yesterday. So, and it is not a significant issue if OHA's count is 740, but the actual count is closer to 7,400.
Well, again, because we have those estimates, we certainly factor that in all of our decision making. So we know that we've got an undercount. We know an approximate magnitude of how much we're undercounting, but we won't ever have an exact number, and I think that's okay.
Okay.
Thank you, Fedor. It looks like we have a follow-up question from Zoe with the St. Helens Chronicle and Clatskanie Chief. Go ahead, Zoe.
Yeah, this is just one more follow-up question, which is about sort of the statement that was made by Tom and Paul about the vaccine being best for preventing severe hospitalization and death. And also having, there's that factor of, the BA2 subvariant, and also what is the case for a young and healthy person to get vaccinated if they do not have a concern over severe illness and death from the COVID virus?
Well, I would say that there is a risk. It is much smaller in younger people, but there is definitely a risk for severe disease in younger people. We know that kids can get this multi-system inflammatory syndrome, which can put them in the hospital and really be quite serious, even if they don't succumb to it. And then, remember that there's the risk of long COVID. This is still being studied, and I think is not all that well characterized, but we do know that some significant fraction of people have symptoms long after they eliminate the virus from their system. And so I do think even in young people, COVID-19 is worth preventing for those reasons.
Great, thank you, Dr. Cieslak. Okay, it looks like our last question is, just kidding, not our last question. We have another follow-up though from Julia Silverman. Go ahead, Julia.
Thank you so much. Since we have a little bit of time, I just wanted to clarify a couple of things. So on the undercount conversation, Dr. Jeanne, is it accurate to say that we've had an undercount for a while, right? Like since COVID tests became more readily available, which if memory serves was around the middle to the end of January. Is that accurate in your estimation?
Well, Julie, we've really had an undercount the whole time because some people who had COVID never got tested. And if they don't get tested, they don't go even to see the doctor. We can't really include them in our numbers. And so, in public health, we really do the best we can with the data we have. And we do have to use modeling and estimations sometimes, but what's changed now is there's a significant number of at-home tests being done because those are relatively recently available. A year or two ago, those weren't really highly available. So we still have the original undercount where people aren't always getting tested, but we also have people who are testing at home, but they just do the test and they throw it in the trash and they make their decisions based on it. But we're not getting that report and we can't include it in our numbers. So again, we're accounting for this in our decision-making and our planning. It's just the reality of our system today.
Thank you, Dr. Jeanne. Our next question comes from Emily Higgins with Box 12. Go ahead, Emily.
I just wanted to ask about any wastewater. Is that part of your modeling system that you're using to get these numbers?
Thanks for the question. Wastewater surveillance is something that we do across the state, and it's one of the ways that we can see in real time where a COVID burden may be increasing. We look at the viral load in the wastewater, and it's really helpful for that. I don't know if it's actually incorporated into the model that OHSU is using, but it is something that we look at on a regular basis, and we also have a dashboard on our website where you can see the counts and the sites around the state.
Thank you, Dr. Jeanne. We have a follow-up from Fedor with the Oregonian. Go ahead, Fedor.
Hi, Dr. Jeanne. I'm just trying to understand the case numbers and the undercount question a little better. So with the estimates of the undercount, let's say it's 10 times, right? 10 times as many as are being reported to the state. Individuals are testing positive through at-home tests, just not reporting that. So if that's 7,400, that is several times more than the peak case count during the Delta wave, say at the peak, right? Where daily we're talking around 2,500 cases, right? So can you help me understand that? Because if that's the case, if the undercount is say 10 times as many people testing positive at home and not reporting that would seem to be quite a significant gap, if that's really if that's the estimate. But that's really where I'm kind of stuck in my understanding.
Yeah, well, again, those ballpark estimates, it's not just the at-home testing that's accounted for there. It's saying the numbers that we're reporting versus the total number of actual infections. And so it's not just because of lack of reporting of at-home tests. It's also just people who didn't get tested. And back in the Delta wave, we had people who are not getting tested. We had a significant undercount there too. So really all along the pandemic, there's been some level of undercount and lack of full reporting. And so I think it is higher now because of that home testing, but it's something that we've known about and factored in all along.
Got it. Thank you so much for clarifying that. Then what if we narrow this down to specifically at-home tests? Like how much of that gap in between the reality and the reported number can be attributed to at-home testing, do you think?
Yeah, I'm not sure I could wager a guess on that. Dr. Cieslak, I don't know if you could either.
No idea, really.
And do you think does it matter?
Well, again, we have really good data on hospitalizations and deaths, and that I think is what is the bottom line here. That's what we really want to avoid. We want to avoid our healthcare system being totally full. We want to make sure people can get the healthcare they need. We want to make sure that people are not having severe illness and complications or long COVID, things like that. And the vaccines are really effective at that. And our numbers bear that out, given where our hospitalizations are now compared to where they were just a few months ago.
Yeah, let me just jump in here and say that I think you can take it as a given that there's a lot of COVID-19 out there. Dr. Peter Graven's most recent estimate, which is almost 2 weeks ago now, kind of looking forward to his updated estimate, but was that 1% of Oregonians were walking around with COVID-19. So, if you're in a crowded setting, you're going to be exposed to the virus. And, what will protect you is whether you've been vaccinated and boosted and to some degree, whether you've already had a COVID-19 infection. There's still a lot of it out there and it's not going away.
Got it. Thank you.
Great, thanks, Fedor. Okay, our final question, and we're going to wrap after this, is from Julia Silverman, a follow-up. Go ahead, Julia.
Sorry, I unmuted before, so you couldn't hear the coffee machine going in the background. I just wanted to ask, I really hear what you all are saying about hospitalization numbers remaining low. I know that Dr. Graven's forecasts have been breaking out helpfully the percentage of people or numbers of people who are hospitalized with and for COVID. But I think that's just at OHSU, right? I can't tell if that's for the entire state. So I'm just wondering if that's something OHA is tracking on the state level as well, and if that changes those numbers of hospitalizations, which have been bouncing between about 120 and 90 for the past few weeks here in Oregon. Thank you so much.
I'll take a crack at that, Tom. The estimates that Dr. Graven generates are for the whole state, but keep in mind that they're estimates. It takes quite a bit of work to try to find out whether someone is hospitalized with COVID, just because they were hospitalized for something else and happened to test positive for COVID, as opposed to being hospitalized because of a COVID-like illness. And his recent estimates have been that it's about 50-50. About half of the people in the hospital with COVID, who still have to have all the contact precautions and airborne precautions and all that. But it's been about 50-50. It's very difficult for us, sitting as we are not within the hospital system, to be able to generate those estimates. But Dr. Graven has done some work doing chart reviews and comes up with his estimates for the state.
Yeah, and I would just add to that the distinction of with COVID versus for COVID in a hospital, it's not quite as simple as it seems, because there may be somebody who presents to the hospital with, an acute kidney issue or an exacerbation of their pre-existing lung disease, but they also test positive for COVID. So COVID may not be their chief complaint, but actually COVID may be the reason. It may be what tipped them over into the hospital and it landed them in the hospital. So it's not always just a simple, binary distinction there between, oh, I just had COVID, but I'm actually here for something else. So it is a little complicated, but yeah, thanks, Dr. Cieslak, for explaining that. So thank you all for your questions. I think that's where we'll leave it today. And we will see you at our next media availability.